start, you can go.
Hello, my name is Kelly Hemasas. I am a parent guide with Guide by Your Side, and today I'm going to be covering a presentation that was originally presented by Stephanie Browning McVicker at the EDDI conference in Louisville last year. The topic today is mandated congenital cytomegalovirus testing, the Utah EDDI experience. So what is PMV? PMV is a common virus that is a member of the herpes family, just like chickenpox is. Affects people of all ages. Most people who are infected with PMV have no signs or symptoms, and then those that do may have experienced mild or flu-like symptoms. I've also been told mono-like symptoms. The virus is generally passed from infected people to others through direct contact with bodily fluids such as urine or saliva. For pregnant women, one of the most common ways they are exposed to PMV is by contact with saliva or urine from children who recently had the virus. When PMV
has arrived.
When PMV infection occurs during a woman's pregnancy, the baby can become infected before birth, and that equals congenital PMV infection. If a woman is infected with PMV for the first time during a pregnancy, that is considered a primary infection. If a woman has already had PMV before her pregnancy, she can still become infected with a different strain of the virus, or the PMV can be reactivated in her system while she is pregnant. That is considered a secondary infection. The likelihood of fetal transmission and symptomatic disease is much greater during a primary maternal PMV infection. It is estimated that 1 to 4% of CMV seronegative mothers, or a negative result in a blood test for the presence of a virus, will become infected during pregnancy, and 30 to 40% of these infected women will transmit virus to the fetus. And keep in mind, there's about 4 million births a year. So again, 1 to 4% is not a huge number when you think of the number of births that are born, number of babies born every year, but still. It's a percentage. Symptomatic, some of the common symptoms, 10% fetal demise, prematurity. I'm not going to be able to pronounce some of these words properly, but hepatomegaly, I have looked it up earlier. It's an enlargement of the liver. Splenomegaly is abnormal large spleen. Petechiae, that was a small red or purple dots all over the body that's basically bleeding into the skin. Jaundice, yellow skin or eyes. Microcephaly, which is an abnormally small head where the brain basically stops growing. Chorioretinitis is an inflammation of the choroid and retina of the eye. And then sensorineural hearing loss, which is damaging the hair cells in the cochlea, or it can damage the pathways, the hearing nerves. Asymptomatic, 5 to 15% of asymptomatically infected children will end up having permanent hearing loss. Again, asymptomatic meaning they don't show symptoms, so any symptoms at birth. About 1 of every 5 children born with congenital PMV will develop permanent problems such as hearing loss or developmental disabilities due to the infection. Congenital PMV and hearing loss is the most common, or congenital PMV is the most common cause of non-hereditary hearing loss in children. In a large number of asymptomatic children with congenital PMV, hearing loss is the only sequelae or known abnormality. Most common cause of non-hereditary sensorineural hearing loss, most common infectious cause of pediatric SNHL, sensorineural hearing loss. Variable presentations, they can present unilateral, about 50%, bilateral, high frequency, all frequency, mild, severe, profound, so just kind of all over the board as far as presentations for hearing loss. 50% have progressive and or late onset, even as late as the 6th year of life, it can show up, hearing loss can. And 3-to-1 ratio for hearing loss for symptomatic versus asymptomatic. Currently, there's not a vaccine to prevent CMV infection. They are working on it. I don't know how far along they are or at what point they're going to release that out to the public. But currently, there is no vaccine. There is an option for treating symptomatic congenital CMV disease in children born with CMV. They have an oral antiviral drug called valganciclovir and Sinclair, I didn't say it wrong. But studies have shown that treatment lasting 6 months modestly improves longer-term hearing and developmental outcomes. There is a different version that when you're in the NICU or in the hospital that they would use, which is ganciclovir, and then they would go home, and this is the oral version of that. And they're seeing results of stabilizing hearing loss and developmental outcomes. So on July 1st, 2013, Utah became the first state in the nation to mandate a cytomegalovirus public health initiative to inform pregnant women and women who may become pregnant about CMV. The law also included a mandate for testing all babies who failed 2 newborn hearing screens for congenital cytomegalovirus prior to 21 days of age. So the Utah EDDI goal, the mandate shifted away from the 136 EDDI model, the one being hearing screening before 1 month, diagnostic evaluation by 3 months, and then early intervention before 6 months. The goal is in Utah now, in order to meet the new CMV testing law, state protocols are revised so that all infants are screened and then re-screened for those who fail the first screening by 14 days of age to allow for CMV testing. It needs to occur within the first 21-day time window because CMV can obviously be contracted after birth. So their feeling is that 21 days, if you start testing them after that, they could test positive, but it doesn't necessarily mean that it was passed in utero. So the new EDDI goal is 1/2 a month, and then 3 months, 6 months. So 14 days screen and rescreen, and 21 days have the CMV testing done. So, oh, and I just wanted to talk a little bit real quick. I didn't bring this slide in, but just in the year that they had done some testing, they basically pulled in kids that had failed their newborn hearing screening twice. And out of those children, 63% went under, 63% of the eligible children had hearing loss. They tested them for CMV, and only 7% of those tested positive for CMV, but that was 12 children. And those 12 children, 5 of them went on to have hearing loss. So again, you can be born asymptomatic, but you have hearing loss. Right now, states do not have a mandate to test for hearing loss. So those 12 children would have not maybe ever known what the hearing loss was a result of. So now they know, those 12 children, that tested positive can be tracked for hearing loss and possible development of delays down the road. So the Utah, or Illinois is a little different than Utah. In May, Illinois House Bill 184 passed legislation that amends the Department of Public Health Powers and Duties Law of the Civil Administrative Code of Illinois. The legislation requires the Department of Public Health establish and conduct a public education program to inform pregnant women and women who may become pregnant regarding cytomegalovirus. On August 21st of this year, it was signed into Illinois law by the governor, and the law goes into effect on January 1st, 2016. So the difference between Utah and Illinois is, well, the similarity is they both have a public health initiative to notify women who may become pregnant or who are pregnant about the virus. The difference in Utah is that if a child does not pass 2 newborn hearing screens, they will test them for CMV. I don't know that Illinois has any plans to do that, but at least this is a step in educating the public about the virus. It was a huge win for Illinois, by the way. So does anybody have any questions? I know I talked a little fast sometimes, so. Okay, I'll move on to the post-test questions. Number 1, what % of children born who show no symptoms or who are asymptomatic of congenital cytomegalovirus infection will end up having permanent hearing loss? A, 1 to 5%, B, 5 to 15%, or C, 15 to 20%.
Okay, question 2.
Question 2, congenital means that a condition is present at birth. True or false?
Question 3.
Question 3, congenital CMV is the second most common cause of non-hereditary hearing loss in children. True or false?
Question 4.
Question 4, currently Illinois has passed legislation that requires the Department of Public Health to A, establish and conduct a public education program to inform pregnant women and women who become pregnant regarding cytomegalovirus, B, test all babies who fail 2 newborn hearing screenings for the congenital cytomegalovirus, or C, both A and B.
Hi, my name is Eva Civicus. I am a parent guide with the Illinois Guide by Your Side. My pay it forward is on the effectiveness of telepractice with infants and toddlers who are deaf and hard of hearing. This presentation was first given by Christy Laser of Idaho State University and Diane Bell at the National Center for Hearing Assessment and Management. This presentation occurred at the 2015 EDDI meeting. The purpose of the presentation was to define teleintervention and its importance, to summarize literature to date that had been collected, and to present results from their 2 comparative design studies. So the question was, why use teleintervention in the first place? Also known as telepractice for delivering birth to 3 early intervention home-based services. They're actually seeing a very big increased demand for services for children who are deaf and hard of hearing, but encountering a shortage of specialized providers. There is little efficacy data to date, and then also providers were having a hard time reaching families that lived in rural areas. So some of the benefits of teleintervention, they collected comments from families, and they thought those were really the most important, was that it was flexible for the parents, but the parents thought in the beginning that it was a little bit more work. And with that comment, they explained that they actually in the beginning had some problems with equipment and connectivity. So the parents were a little bit frustrated with that. Another benefit was that the family didn't have to cancel if the child was sick, had a slight cold or something like that. They were still able to actually have the session. So that was less missed sessions, less missed visits due to being sick or encountering bad weather. Parents also stated that they gained confidence in their own ability to help their child through the direction of the provider. They were also able to do teleintervention while away from home. So if they brought their laptop while they went on vacation or at grandma's house, they were still able to have their therapy session. And overall, basically, it was just convenient for them. Some of the telehealth challenges that they did come across was the connectivity was problematic in remote areas, the provider and administrative resistance to technology happened. There were some issues with understanding privacy and security issues with HIPAA, and then how safe things going over the internet were, how private. And then also with reimbursement, they realized that a lot more legislation was needed. I believe that according to the Medicare, they have to have at least one in-person visit in order to get paid for it, or a face-to-face visit. So I guess they were kind of trying to argue the point that, like, through Skype or FaceTime was an actual face-to-face visit, even though they were not physically there with each other. So then what does the literature tell us about teleintervention effectiveness? There were 6 studies done in 9 years. So in 2006, there was a descriptive study that showed parents were satisfied with remote screenings, evaluations, interdisciplinary care, but that was done with school-age children. In 2009, there were 3 studies done showing that OT, PT, speech and language, and psych services were viable through TI. There was a study that showed OT was cost-saving and parents were satisfied, and another one that showed that there was a savings of time and resources. In 2010, there was a study with clinical sessions resulting in equal progress for children and family perceptions, and the latest one, which Diane Bell was a part of, showed that there was a high family satisfaction. The evaluation model that they used basically started with describing the delivery system that they were using. So the services were provided using Skype or FaceTime-like video-based communications. At least 2 of the sessions were through teleintervention, but they did have to have 1 face-to-face visit, like I said again, for that Medicare reimbursement. But all of the PI sessions were recorded. The service delivery outcome that they modeled after was that they were going to show that it decreased travel time, intervention costs, there were fewer canceled sessions, flexible scheduling, increased the number of program service hours available, and a greater adherence to intervention principles. So the provider skill outcome was that there was a greater use of parent coaching. They increased the use of natural environment. So with the child being in their own home, they were able to include the family's culture, the family's routines, other members of the family. The services were more family-focused instead of provider-directed. And then for the provider, it increased self-assessment and feedback with the recorded sessions. So basically, the provider was able to go back, review the sessions that they had, and kind of almost like self-critique themselves to what they could be doing better as well. For the caregiver outcomes, it increased the caregiver engagement in the intervention. There was more self-efficacy in meeting the needs of the child who's deaf and hard of hearing. There was positive and family-child interaction, again, using the natural environment to improve the child's outcome. Same with family participation using recorded sessions. Mom or dad or whoever could go back and look at the recorded session again to see what the provider had directed them to do in case they forgot. And the overall increased the caregiver satisfaction with services and the delivery of them, and it decreased the cost to obtain the services.
Has arrived.
It improved the child's language, cognitive, and social skills, improved the child's responsiveness to caregivers and family members, and increase the use of technology for the parents. The child and family characteristics, basically they had 27 families, so 13 were in the teleintervention group, 14 were in person. The average age for the kids in both groups was between 18 and 19 months old. 6 boys, 7 girls in the teleintervention, 4 boys, 10 girls in the in-person group. 3 of the children in each group had additional disabilities. 2 of the kids in each group had a cochlear implant, and the communication modality was pretty similar. So in that first study, they compared the outcomes of families and children who received services through the TI model and the in-person. It was a randomized trial. Like I said, then all the TI group got all of their visits but one via Skype or FaceTime. It applied to the existing AI program intensity. So if the child was to get, an hour and a half of therapy per week, that's what it stayed at. And then the cost-effective study was came out with results for the child, the family, and the provider. So the child outcomes in that study, as you can see, the chronological ages of the children in both groups when the study was complete, so they were right around 24 months. And each pretest of the language development scale, where they placed in both expressive and receptive languages, was pretty similar in both groups. In the expressive group with the in-person kids, there was an increase of 4 months, but in the tele-intervention group, there was an increase of 7 months. And in the receptive language, the in-person group increased by 4 months, but the TI group increased by 6 months. So TI was a very significant factor in the expressive language, which kind of basically they were just stating that the more parents are involved, the better results. Cost data, I was a little bit confused by this, and they really didn't kind of break it down into what the cost savings were. As you can see, they started with the initial $1,000 cost loss for equipment and connectivity. So doing 1 visit per month with each family was not cost effective at all. The more TI visits, the more savings. So saving drive time means that you can see more kids. I wasn't sure if the Utah early intervention providers were independent contractors or if they were employed by the agency. So I think if they're employed by the agency, that's where the most cost-effectiveness comes in, because they are getting reimbursed for mileage, for parking, for tolls, different things like that. So I really wasn't sure, because no matter how many families you have, you're still putting out that initial cost for equipment and for connectivity. So, and then I did a little bit of research, and I do believe that Utah EI does reimburse for all of that. So that's where the cost savings come in. So instead of driving an hour and a half to see a family, if you're doing it inside your office for that 1 hour, you can get a couple of more kids serviced throughout the day. Just a little bit of the results regarding the technology and connectivity assessment. It showed that the time of day didn't really make a significant difference when they were doing the TI. And with the errors were similar between people and locations. So kind of first starting out, sometimes the parents or the provider weren't really sure how to connect, where they should be looking, if there was some sort of interruption or anything like that. they weren't really sure how to log back on and try to get reconnected. They did see that video had the fewest errors per minute, regardless of the download speed, but eventually it just shows that the better speed, the higher quality and upload speeds you will get. So to them, connectivity and I believe it was bandwidth was key. So this chart was a little bit hard for me to read because it kind of just went from strongly agree to disagree. So an easier way to read this is that before the study and after the study were conducted, more providers said that they would recommend TI services to peers after they went through it. More providers said that they think TI works for families who use technology often. The more they use it, the easier it is for them. Also, more providers stated that the caregiver does most of the interacting with the child as opposed to them. And then more providers said that they would use Skype in their personal life and actually practice before actually having sessions with families. The second study that they did was pretty similar to the first one. The only differences was that they used multi-sites, more families, but basically it replicated the study findings from the first one. They just had a larger sampler size, additional standardized child measures, and the diversity in the hardware and software. So instead of just using desktops, they also used iPads and tablets. So the second sample size, as you can see, there was a total of 48 families that completed the study. 6 of the families dropped out. They really didn't explain why. They just said a couple of them chose not to, a couple moved away. Or I believe a couple of them might have aged out of the program. But between those 48 families, they had 15 different providers. So they had a nice variety of experience of providers. Okay, so with the second study, there is a chart here of the pretest.
Melissa Joyce has left the conference.
With the, oops, I'm sorry. With the pretest scores of the preschool language skills in receptive and expressive, they combined that just for a total score in both of those. And the MBCDI is the MacArthur-based Communication Development Inventory, and the ASC is Auditory Skills Checklist. So pretest, the TI group scored lower than the in-person, except for the auditory skills checklist, which were very similar. But basically every child in the TI group scored lower before the test was done. This is a chart of the post-test outcomes. And as you can see, the TI group scored higher in all of the categories than the in-person group. So once again, just kind of reiterating their findings that the tele-intervention is really working well when it is pretty much caretaker-based. So the overall conclusions from these studies were that TI has been shown to achieve child outcomes equal to, if not better in some cases, than in-person sessions. TI equal to in-person sessions regarding family outcomes. TI supports that coaching model of enhancing the parent's engagement and the provider responsiveness. TI can also support routine-based activities in the home, and TI can save program costs depending on the equipment used and provided to families. Oh, sorry. And that's it. Any questions? Okay. Do you want me to start with the post-test?
Yes, please.
Okay. Number 1, what is teletherapy? Talking to your therapist on the phone, intervention services provided by video-based communication, recordings of therapy strategies, or calling your friends to complain.
Question 2, please.
What issues does teletherapy solve? A, alleviates the shortage of specialized providers. B, provides access to those in rural areas. C, which is both A and B, or D, not having to clean your house.
Question 3, please.
What are the benefits of teletherapy? A, less cancellations due to weather or sickness. B, the parent gains confidence in their ability to help their child. C, flexibility in scheduling. Or D, all of the above.
Question 4, please.
What are the challenges in teletherapy? A, connectivity problems in some areas and reimbursement. B, provider and administrative resistance to technology. C, scheduling around watching YouTube. Or D, both A and B.
Hello, this is Allison Rollins. I'm a parent guide with Guide by Your Side, and I'm doing my presentation that took place at the EDDI conference in 2015, originally by Susan Wiley and Chris Yoshinaga Itano. It's about considerations and assessment of autism spectrum disorder with children who are deaf and hard of hearing. So, dual diagnosis is really difficult in children with hearing loss. So since EDDI was established and kids are being diagnosed way earlier in infancy, it's harder to find and see kids with autism at the same time. Kids are implanted early, but they still have hearing loss and they still are not showing they're not developing as well, but it's kind of not known why. The therapists have a hard time knowing why the child is behaving that way. Also, there are no screening devices that are out there. Most of them are questionnaires, and they have not been done with deaf and hard of hearing children. So when parents go to their doctor, most of the questionnaires were based on hearing children, so it might not apply to a child with hearing loss. Within the deaf and hard of hearing population, the incidence of autism is increasing relative to those who don't have hearing loss. Around 4% of children who are deaf and hard of hearing fall within the continuum of autism spectrum disorder. So it seems like it's not very high, but in my field, in my practice, every day I'm seeing more and more kids. So I don't know if that percentage, how accurate that is. Some of the common red flags of a child who has hearing loss and possibly autism spectrum disorder are that they have difficulties with direct attention. They don't respond to their own name. They have difficulties understanding other people's needs and feelings or processing their facial expressions. They have reduced pointing for things and poor understanding of integrated ASL facial and grammatical features. And some more red flags. When using sign language, there are palm reversals, so a sign like book that you'd have your hands closed and then open for book, they would actually do it backwards. So the palm would start up and then it's opposite of what the sign should be. A lot of times they don't use pronouns, so instead of I, you'll hear them often referring to themselves, which is common in really little kids anyway, but this continues on as they're older. And then when they have maybe a home sign that they've developed, that usually persists even though the signs have been taught repeatedly. They don't pick up the new sign, they still continue with the home sign. So if they learn to sign like red for ketchup, but then they go to school or the therapist starts teaching them the sign for ketchup and they do it repeatedly, the child still would sign red every time they wanted ketchup. Also, kids' play is more rigid and less imaginative. Sometimes they have unusual social overtones, so they are grunting at their peers or hitting them, or they're just not interested in what their teacher or their peers are doing or feeling. But the problem is that a lot of these are also diagnosed in children who have ADHD or OCD or sensory integration. So again, it's really hard to diagnose definitively whether or not the child with hearing loss has one of the other disabilities or really does have autism. There is no standardized assessment for kids with hearing loss right now. So usually what happens is there's a provider that is trained in kids with autism or a provider that's trained in working with deaf or hard of hearing children. But there's very few, if any, teachers of the deaf that also have expertise in autism. So finding people who are interested in generating and growing their skills across both areas is going to be important because as it is in the hearing community, it also, as I said earlier, is on the rise. So it's going to be important possibly for schools to start training teachers heavily in both instead of just one or the other. Sometimes if there's an interpreter involved, it makes it even more complicated to diagnose. So if the therapist knows that they're going to need the interpreter and can meet with the interpreter or speak with the interpreter ahead of time, that's always helpful so that the interpreter knows what to expect. Maybe the therapist can try to teach the interpreter some of the nuances that that particular child uses when they're communicating so that when they do communicate, the interpreter can interpret it correctly instead of incorrectly. There's 3 different ways that they are trying to assess the dual diagnosis. One is to look at the social quotient and whether or not that's going down. So they do the questionnaire repeatedly and see as time goes on if the results go down. So maybe they're social and very social and involved when they're younger, but then as they get older, they're less and less interested in what other people are doing and other children. And then another way is to look at their symbolic play and gestures. So the classic example is if the child is just playing with the car back and forth, back and forth, back and forth, or just looking at the wheels over and over, but not playing with it and pretending it's going on the road and making noises and all kinds of things. That's another way of diagnosing, or at least a red flag about it. And then the other way is to use the LINA, not the LIRA, which has an autism screen that's designed for hearing children. and it's very specific and sensitive with the hearing children that are later diagnosed as autistic. So it's very, very accurate, 96 to 97% when they use that as a diagnosis. So for intervention, it's important to use the whole team, possibly have the autism expert and the teacher of the deaf working together side by side. In Denver, there's the Denver model, and basically it's getting everybody together who's on the team and doing the same intervention and deciding on 3 specific interventions that they're going to focus on for a 6-week treatment. And everybody, all of those therapists and the family will continue to work on only those 3 defined goals, and hopefully that will help improve. And there is a training program for parents and other therapists that's using this Denver model, and it's based on home intervention with the parent. Also, another therapy is using the ABA method. They gave some resources for families. There's an article written called Seminars in Speech and Language Special Edition, and it's on the EDDI website. And then Hands and Voices also has a Deaf Plus category that parents can find information. And that is it. Any questions? Okie dokie. Should I go ahead?
Yes, please.
All right, here's one. Okay, post-us questions. 1, it is easy to diagnose deaf and hard of hearing children with autism. True or false?
Question 2.
Children are diagnosed with both hearing loss and autism at the same time. True or false?
Question 3.
Common red flags in children with hearing loss who also are on the autism spectrum are A, palm reversals, B, limited pointing, C, limited use of facial expressions, or D, all of the above.
Question 4.
One method of assessment to diagnose ASD in children who have hearing loss is the use of the Lyra device. True or false?